This is the second in a series of presentations on the topic of radiography of musculoskeletal trauma. In this presentation, we're going to describe a few fractures specific to the horse, probably more encountered by those of you who will have an equine specialty practice, but several of you who are mixed animal practitioners may encounter these. And those fractures are listed on the bottom of the slide, and by the end of the presentation, you should be able to identify and describe these 4 fractures. Let's start with the foot and talk about fractures of the distal phalanx. These fractures can be quite challenging to identify, and they must be distinguished from packing artifacts and the normal vascular channels of the distal phalanx. It'll be really important to clean and pack the sole as much as possible prior to taking your radiographs. And if you take radiographs and then you're unsure if it's an artifact or not, just go ahead and clean it out and repack it again and take another radiograph. On radiographs, we're going to look for a radiolucent line or lines that are separate from the normal vascular channels, and typically they take a different course than the normal vascular channels. However, there are times that we may not be able to identify them on our standard views, and if you're highly suspicious of a fracture, then you might need to take multiple off-angle views. If a fracture is suspected but you do not identify it on the radiographs, first, consider repeating radiographs in 7 to 10 days. By that time, the fracture line should be more evident due to the bone resorption that takes place as part of the healing process. If you remember, we said that after about 5 to 7 days, we can see lysis, which would be resorption on a radiograph. Or you could consider pursuing additional imaging options such as nuclear scintigraphy, CT, or MRI. And the small image at the bottom right of the slide is a bone scan of a patient. This is the distal phalanx, and this is a radiopharmaceutical uptake at the level of a fracture. As always, we like to classify things, and so this slide shows the different types of distal phalangeal fractures. The diagram will hopefully try to depict these as well. So type 1 and type 2 both involve the wing, or more appropriately, the palmar or plantar process of the distal phalanx. Type 1 is non-articular, so it doesn't go into that distal interphalangeal joint, but type 2 will actually extend into the distal interphalangeal joint, typically a larger fracture segment. Type 3 is a mid-sagittal fracture that's also going to go into the distal interphalangeal joint, so that's also articular. Type 4 is actually oftentimes really an avulsion fracture, and that is a fracture of the extensor process. Remember, there's a tendon, either the common digital extensor or the long digital extensor, whether you're in the front or the rear limb. And then type 6 are interesting. They are fractures that happen along the solar margin. So they're usually just these little, like chip-like fractures. And then type 7 is specific to the foal, and that is also an articular, palmar or plantar process fracture. But again, it's specific to the foal, so they have listed them as type 7. So I have a few examples of the various types. So this first one is our dorsal palmar oblique view of the distal phalanx. Notice this patient still has a shoe in place. Ideally, we would remove the shoe, but the shoe can be used to stabilize the hoof capsule and provide support if you are suspicious for a distal phalangeal fracture, and so sometimes you'll take radiographs without removing that shoe. And in this patient, here's a fracture line with some displacement of a portion of that palmar process. And notice it does not go into the distal interphalangeal joint, non-articular, so it's a type 1. This is a lateral and kind of a special lateral proximal medial distal oblique view of the palmar process of this patient. Notice on the lateral view, I actually can't see the fracture, so this is why we oftentimes need additional views. But in this patient on this distal phalanx, I can see the fracture line. Remember, the vascular channels are going to be radiating out from that solar canal. So I can see the fracture line that is actually going into just the edge of this distal interphalangeal joint. It's of that palmar process, so it is a type 2 fracture. The patient on the left has one of the mid-sagittal articular fractures. So here's our distal phalanx. This view is a little bit overexposed, but here is the fracture. It looks like there are more than one fracture line here, and that's really because we're seeing the dorsal part of the fracture offset from the palmar part of the fracture. So this is one single fracture, so type 3 mid-sagittal fracture. I might have forgotten to actually mention about type 5 when I was talking about the different types, and that would be a fracture that would involve kind of the middle portion of the distal phalanx, but that would be a comminuted fracture. Here's a lateral view of a distal limb in this patient. This is a fracture line that is at the base of that extensor process, so this would be a type 4 fracture. I don't have a good example of type 5. We don't see them quite as often as the other fractures, but this is an example of a patient that has the type 6 solar margin fractures. So compare this side of the solar margin. It's a little bit irregular, but it has bone opacity all the way to the edge. When we come up to this side, we have these lucent lines here running in a different way than the normal vascular channels, and so these are the type 6 solar margin fractures. Moving up the limb, another kind of equine specific fracture is a proximal phalangeal fracture, and the one I'm going to talk about is not kind of like the traumatic comminuted fracture that we saw in our other series, but we're going to talk specifically about a dorsal proximal osteochondral chip fracture. These can be seen in racehorses as a result of hyperextension, but we do identify them in horses of other uses. And these are little chip fractures that come off from that dorsal proximal aspect of the proximal phalanx. And so radiographically, we're looking for an osseous fragment that is adjacent to a defect in the proximal phalanx. And although they can happen on either side, the dorsoproximal medial aspect is a common site, so that medial eminence on that proximal phalanx. So one common site to be looking for if you're suspecting this. So I have one example here. We have some more in lab, but here's one example of a patient that has one of these chip fractures. In this patient, I want to call attention to the fact that the lateral view and the flexed lateral view can both be helpful. So on the lateral view, I see one osseous fragment here that is separate from what looks to be a little defect in the proximal phalanx. When we do a flexed lateral view, we can see that fragment actually stays by that defect in the proximal phalanx. Later, we will talk about a developmental disease that happens in the sagittal ridge of the third metacarpal and metatarsal bones. And if that fragment was associated with that, it would stay in the area of the sagittal ridge, which would also have another abnormality. So again, lateral, flexed lateral can be quite helpful. And then on our DLPM and DMPL, when we start to really look closely at this patient, here we're looking at the dorsal medial aspect. Notice here would be our dorsal medial kind of eminence. There's a line that's separating out a piece of bone from the proximal phalanx. This one's not very displaced, so this is actually not the fragment we saw on the lateral and flexed lateral view. When we look at the dorsolateral aspect of this patient, now we can see the first fragment that we saw, and that is displaced from a small defect in the dorsolateral kind of eminence of this proximal phalanx. So this patient actually has two chip fragments, and one is on the medial side and one is on the lateral side. And it's really important to get your complete study, because if we're going to manage this typically with arthroscopy, we need to know that there's more than one that we have to take out. Continuing proximally, let's talk about a disorder that affects the predominantly the metacarpal 3 bone, sometimes the metatarsal 3 bone, but really is typically in the front limbs. Dorsal metacarpal disease, you may have heard it called buck shins, is a relatively common kind of disorder that happens in the training or racing thoroughbred, standardbred, and quarter horse. And that is really when you oftentimes are overtraining them the bone has a non-adaptive stress response. And so the dorsal cortex of that bone gets thickened, which is not adaptive, and then they can actually get little microfractures in that dorsal cortex. This is a bone scan, a lateral image, showing the third metacarpal bone, and all of this intensity here is abnormal, should be the same as the proximal and the distal part. So this is demonstrating this dorsal metacarpal disease. Why it's important to recognize that that's happening is that if we don't recognize it, the patient keeps getting trained, it can have further maladaptive response to stress, and then that can actually lead to these dorsal cortical fractures. When they actually have the fracture that we can identify, we are going to look for a radiolucent line in the dorsal cortex, oftentimes in the dorsal medial aspect, but it can happen in the dorsal lateral aspect as well. Typically, even before we see that radiolucent line, we may identify cortical thickening that can be both on the periosteal and endosteal surface from reaction, and that's kind of that initial maladaptive stress. And so most of the time to see the fractures, we do need to get our off-angle views. So here's a patient on the lateral view. The normal cortex up here, we can see that it is thickened here from a solid, so non-aggressive appearing periosteal reaction, but also there's some endosteal reaction here leading to a little bit more sclerosis. So that is that cortical thickening. I don't see a fracture line here, but when I look on the DLPM view, I can actually identify the fracture line, which in this patient is more on the dorsolateral side, which is why it's superimposed over the mid portion of the bone. And notice we can see that kind of endosteal and periosteal reaction looking like sclerosis. So these are incomplete fractures. They usually start out distally and then go through the cortex proximally. So again, incomplete fractures. On the other off-angle view of this patient, again, I can't see the fracture line very well, but I can see that periosteal reaction that's along the dorsolateral cortex, and that's the reaction that is associated with this fracture. And then we'll finish out talking about carpal fractures, which certainly other patients can get carpal fractures, but these are some specific fractures to horses. And they occur not uncommonly due to poor conformation, like back at the knees, but also occur during hyperextension injuries, such as with race horses or barrel horses, or even direct trauma, so a kick or running into something, so blunt trauma. There are chip and slab fractures, and chip fractures are going to be very small, and they typically involve like a corner of the bone, and they involve only one joint surface. The flexed lateral view of the carpus is a very good view to use, and I have just used this normal horse to indicate with arrows where we identify these chip fractures. Distal radius at the intertendinous eminences, that's a very common site, so it has an asterisk. We can see them on the proximal intermediate and the proximal radial carpal bones, and then more commonly we'll see them on the distal intermediate and the distal radial carpal bones, and then sometimes we'll see them on the proximal third carpal bone. So it's important for you to remember where these common sites are so that you know where to look, and whenever we identify one, we need to look for more, and we need to see if there's anything additional as well, because again, when we go into do arthroscopy to take one of these out, we want to make sure we get everything. We can also identify slab fractures, and those are axially aligned, so along the long axis, and they will go from one joint to the next joint. So we might see them in the intermediate or the radial carpal bone and the third carpal bone. Radial and third are probably more common, and again, they will involve the surfaces of two of the joints, the joint above and the joint below. Here's an example, select views from a patient that has chip fractures, and I want you to recognize as I point these out that they are quite small, but yet they can cause quite a bit of lameness and swelling. So on this lateral view, I see quite a bit of soft tissue swelling here that is centered at this middle carpal joint. So this would be joint swelling or intracapsular soft tissue swelling. Remember, in the horse, there are radiolucencies, which are fat opacity. There are carpal fat pads that are just dorsal to the antebrachial carpal joint. That helps me identify that the swelling isn't in that joint. So joint swelling centered at the middle carpal joint. I don't really see an abnormality, but when I then do a flexed lateral view, which is so important, I do notice on the distal margin, and these are dorsally, usually when they are, like the typical chip fractures. On the distal margin, there are 2 little osseous fragments and a defect in that distal part of the radial carpal bone. So these are 2 chip fractures. Here's a different patient. I have, again, the select helpful views. So this is our DLPM view of the carpus. This is the flex lateral view of the carpus. And this is a flex lateral kind of oblique view to show additional lesions a little bit better. So in this patient, although the lateral view is way better to identify soft tissue swelling, there is a little bit of soft tissue swelling that seems to span the antebrachial carpal joint the most. When we do a flex lateral view, it kind of stretches out those soft tissues. On this view, I see a small, tiny little fragment and a little bit of a irregularity defect associated with this distal radius, so at the dorsal medial aspect. On the flex lateral view, I can see an additional small little fragment here that's coming off from one of the intertendinous eminences, and then it looks like there is another fragment that is coming from the intermediate carpal bone. And then on this kind of oblique to flex lateral view, this is that same fragment we saw on the intertendinous eminence, but now we have identified a little bit larger fragment that is coming from the radial carpal bone. So this patient actually has 3 different chip fractures to address. And again, notice how small these are. And then here's an example of a slab fracture. This patient had trauma, so this isn't a typical location. But this is our second carpal bone here. And when I look at this patient, I can see irregularity and maybe a little bit of fragmentation, and then a larger axially aligned fragment that has association with the middle carpal and the carpal metacarpal joint. This is a skyline view of that distal row of carpal bones, and here is our second carpal bone, and here is that slab fracture with additional little fragments. Keep in mind that we have those additional skyline views of the carpus that can be so beneficial. And if you have standard views of the carpus, we have swelling and lameness, and we don't identify things, then it's really prudent to obtain flex lateral and skyline views. In both the Thrall and the Butler et al. Clinical Radiology of the Horse are textbook chapters that if you want to see some more information and examples regarding these specific fractures, you can just look in the index to find them.